Hi, I'm Louise, also known as the Modern Midwife. I am, of course, a midwife and also a mum to my gorgeous baby girl, Georgie. Today, I'm joined by the lovely Stephanie, who is also a GP and a mum of two. So Stephanie, there's still so much stigma attached to periods and menstrual cycles, and as healthcare professionals I think we have quite a crucial role to play in that space in general, but in particular in understanding people's symptoms, discussing those symptoms with them, and also education. But why do you think there is still that stigma or almost awkwardness attached to those conversations?
Yeah, I think you're absolutely right. It is a stigma, it's a taboo. I think also there are a lot of myths that surround the topic of women's health in general. And so as a result, I think people would just be a little bit less aware of problems that they can go and speak to a GP about, but also less education as well about what's going on during your period, what's normal as well. Again, the patients that I see, I think it's difficult to pin down exactly what is normal. If you go onto a reliable resource like the NHS website, for example, it will say that a menstrual cycle is about 28 days. But I mean, we know that that can vary hugely from person to person. And it can be difficult for people to know, well, is what I'm experiencing, is that normal? You know, what is it that I actually need to flag up to my GP? And so I really think it starts with education and also normalising the discussion around women's health topics, and especially when it comes to periods. But also, I guess if we take it from a wider angle, talking about pregnancy, you know, people, those groups that are also vulnerable to having lower iron levels as well. Tiredness and fatigue is such a common symptom for people to experience, and just being able to delve a little bit deeper and trying to find out the root cause as well, I think is important. But I think that's why it's great that we're having this conversation about it. And like you said, I think we as healthcare professionals definitely have a responsibility to almost kind of fly the flag and raise awareness about it.
Is there anything else that you think that we should, or you should as GPs, for example, be asking women specifically in relation to their menstrual cycle?
Yes, so I mean, like you said, I think tracking menstrual cycles is so helpful. And actually, as a GP, when people come in and they say, well, you know, you can have a look at this app that I've got and you can see that this is when I had my periods, that's so helpful. It's almost skipping a step in a way. So instead of me saying, well, actually, could you go away and track your cycle and come back with this information, you've got a bit of a head start when you come in. So that's a brilliant thing to do. And also it just means that you're taking control a little bit more of your own health. But other things that I think that we have to be mindful of as GPs is really delving into the true history, taking a menstrual cycle history, instead of just maybe asking a question, oh, so are your menstrual cycle, is that all okay? It can be quite easy if you're a patient just to say, oh, yeah, they're fine. But actually, again, like I was saying before, what is normal for one person might not necessarily be normal for someone else. And so for me, I think the real key thing is to try and establish how heavy people's periods are, because I think Active Iron, they did this research which showed that 67% of women do have heavy periods. And actually some of them might not even know that. They might think, well, this is normal. So being able to say, well, what sort of sanitary protection do you use? Are you using maximum absorbency? How frequently are you having to change that? Do you ever leak through? What happens at night time? You know, are you passing clots? Things like that. I think that can help just to give a lot more information about it. And certainly I've seen patients where they say, oh, yeah, you know, they describe what actually sound like very heavy periods to me, but for them, they think that that's normal. So I think that that's a really important part of taking the history when we're seeing patients.
Yeah, exactly. From a midwifery perspective as well, I find that women are fairly well educated during pregnancy in regards to the supplementation that they need to take and being mindful of their iron intake. And of course, we do test their iron levels throughout pregnancy. However, once they've had their baby, I find this is a very common theme throughout, not just from the perspective of losing blood, but also during that postnatal period, it's almost like we say they're a pregnancy princess, and you know, they get lots of care and lots of information, and then when they have the baby, actually that starts to dwindle, and it's very hard to look after yourself and also look after a baby. And often women's needs get pushed aside after birth, and they forget to take postnatal supplements, and they forget to be mindful of the fact that they are bleeding, and it can be fairly heavy after you've had a baby, and sometimes women can even lose clots and things that, of course, as we know as healthcare professionals, that does need to be discussed and potentially investigated. But women do lose a lot of blood after birth as well, and sometimes can bleed for some amount of time and completely forget to take any sort of supplementation because they're so busy looking after their baby. But feeling fatigued and tired can be fairly normal in that postnatal period, but it doesn't mean that there's nothing you can do about it. And continuing to take a supplement, or just taking a supplement such as active iron, can really help to get on top of those symptoms, can't it?
Yeah, I completely agree. I think both of us, we've been through that postnatal period as well, and like you said, the focus can very much be on the baby. But I always think that I see my role as a GP, especially when we see new parents at the 6-week check, for example. I feel like then is such an important point to check in with mum and make sure that they're doing okay, and to check on the bleeding as well, because like you said, you can have lochia, which is blood loss for up to 6 weeks sometimes, and that can still continue to be quite heavy. So you always want to check in with those symptoms as well. And yeah, we're the ones who are there looking after baby, but I like to think that we're the ones who are watching out and looking after mum as well.
Absolutely, and reminding them of what they need to do, because it is, as mentioned, it is so easy to forget. And in particular, if you are breastfeeding, then that's another requirement of your body, and that ongoing requirement that that baby is still very reliant on you for ever so much. And then you put food on top of that, and you know, mum starts to become deficient and starts to become even more tired. So one of the findings from the study undertaken by Active Iron showed that as much as 54% of women don't seek any support or advice whatsoever from a healthcare professional, which is quite shocking, I think, for us to learn. And even more so, those women that are at risk may not even know they're at risk. So for example, those groups of people being those that exercise particularly regularly, such as athletes, perhaps those that have more of a restricted diet, pregnant women, and they may not even know that they are in those at-risk groups. And to further that, the majority of women aren't seeking help and support from healthcare professionals. So I do think that it is partly our role to open the gate, so to speak, for that conversation when we do see our patients. And I'm sure that you've come into contact with several different women that do require iron supplementation.
Yeah, exactly. Like you said, all of those groups are very vulnerable, and we do see them in clinic day in, day out. And even if you do get to the root of the problem being low iron levels, once you've prescribed some iron supplementation, the real problem and the thing that I come across, the biggest obstacle really is compliance, because they will experience things like constipation, GI side effects as well. And so that becomes a real issue. Like you said, there have already been so many barriers to getting to the GP and getting diagnosed. For them to have side effects with a supplement is actually really problematic, and can sometimes actually in our professional capacity, what we want to do is try and help and make things better. And so it can be frustrating to feel like you've identified something but there isn't an effective treatment. So actually now knowing that there is something else such as active iron, which does exist, which is kinder and still strong, that's really valuable.
Yeah, absolutely. The other thing that I found really interesting was the statistic that 91% of women didn't consider how much blood they lose during their periods as well. And not making that connection is really common, and actually embarrassingly, as a midwife, I didn't make that connection with all of the knowledge that I have. So I think as healthcare professionals, it's really important not only that we are actually looking after our patients, but we're also looking after ourselves and considering that ourselves.
Yeah, I completely agree. I think I've been in exactly the same position before, where you think, you've got the knowledge, we should know and we should be aware about it. And so actually, if you extrapolate that and you look at the general population, you can definitely appreciate that women are not going to be aware of that at all.
Yeah.
And also it's, whilst we can be more mindful to eat the right foods and try and get iron from the diet, it can be difficult to get everything you need, your total iron requirements from that. So during your period, on average, people will lose about 80 millilitres of blood, and that can contain between 220 to 250 milligrams of iron. Yeah. And to put that into context, that's like eating 1 kilogram of spinach, which is obviously a huge amount and sometimes not always possible, especially if you're not eating other iron-rich sources like red meat, for example. So, and there are other things in our daily lives, like drinking tea or coffee, that can inhibit iron absorption. Yeah. So it's really important to be aware that as much as we can be mindful about trying to have a lot of iron within our diet, it might not always be possible. And that's where iron supplementation, that recommendation for patients can be really helpful.
Yeah, exactly. And I think that's a really good point you touched on as well, about not taking it with tea and coffee, for example, and actually taking it with vitamin C, because we know that iron is far better absorbed. And that is, sometimes we can forget to tell our patients that, can't we? So we send them on their merry way with what they need, and then forget that really crucial bit of information about when you are taking the supplements, make sure that you are taking them according to best practice.
Yeah, exactly. And certainly with the patients that I see, if I end up prescribing them iron supplementation, usually the review will be about 3 months after, just to see how they're doing. Yeah. And the problem that I find is the compliance, really. The typical iron tablets that you would take would be 3 times a day, but there are a lot of side effects that can be associated with them. So things like constipation, gut irritation as well. And so naturally, if you're thinking about people leading busy lives, they're not going to take that as frequently as they need to. And so it's this, you run into this stop-start cycle, and it can be very difficult long-term to actually be able to support the iron levels to the amount that they should be. So something like active iron, which we know causes 6 times less gut irritation, for example, that will definitely lead to more compliance in the long term.
So as a healthcare professional, I'm sure, as are you, always really excited to hear about new research, which is why I am delighted to be joined by Professor Mark Ledwidge, who is joining us today to discuss the clinical trial that was most recently undertaken by Active Iron.
Really nice to meet you, Marie. I'm a pharmacist and I'm a UCD professor in the School of Medicine in University College Dublin. And I was actually one of the people who invented and developed Active Iron.
Can you tell us a little bit more about the clinical trial and your findings, and specifically more around the statistics? So, as healthcare professionals love a statistic to quote and reference.
Before helping to develop Active Iron, I wasn't really conscious of adverse effects with oral iron and how severe they can be. Now that I look back on it, I realize that for more than 150 years, the medical and pharmaceutical approach, which is probably a very male-dominated approach to physiologically poor iron absorption, it was effectively to overdose patients, predominantly women, and that's not right. And when patients complained about the side effects, when I was being trained, we were taught to encourage persistence rather than solving the problem. And then more recently, we see some good data to show that alternative daily dosing can give quite good iron absorption and give side effect-free days. But this is also a form of encouraging persistence rather than solving the problem. So, we need more awareness that, 2 in 3 women have experienced heavy menstrual bleeding, that 1 in 3 experience it regularly, and yet few people really seek help from healthcare professionals. So we probably need more clear messaging, more accessible definitions. We need better education and maybe more of an openness amongst healthcare professionals like, nurses, midwives, pharmacists, doctors, to initiate the conversation that that women might need. What we did in preparing for this new study is we looked at the literature and found that even though everybody knows, it's almost axiomatic that bad side effects causes poor compliance, which causes treatment failure, there wasn't really that much data in the literature. And in fact, even though everybody is aware of the side effects of iron, it's actually poorly researched, it's poorly documented, and non-standard definitions are used. So what we thought would be interesting is to look at the prevalence of low iron, of iron deficiency, and then also of iron deficiency anemia amongst women who self-report a history of poor tolerability to oral iron or adverse effects, particularly adverse GI effects with oral iron. And what we found was that a majority of 204 women that we screened in the clinic, in other words, 128, almost 62%, 2 out of 3, had a ferritin level less than 30 micrograms per liter. Just over 3 in 10 had what we would term moderate to severe iron deficiency, and then 1 in 6 had iron deficiency.
And they were unaware of that otherwise?
What was really interesting, Marie, is that there was no relationship between the prevalence of low iron and a previous diagnosis or a history of either iron deficiency or of iron deficiency anemia or even anemia. And in fact, only 17 of the women had, or at least self-reported, a previous diagnosis. Now, that's not to say it wasn't done and they didn't recall it or it wasn't properly explained to them, but the fact that the majority of these women were unaware reflects the survey data that we've seen recently, showing that women with heavy menstrual bleeding and iron deficiency don't tend to seek out help from healthcare professionals perhaps as they should. So one of the things that we did then in our study is we prospectively recruited 60 patients or 59 women out of the 128 to go and take active iron at 3 different doses over a period of 12 weeks and to try and number one, to try and assess how in this vulnerable group they would take active iron, because it's designed and formulated to be less problematic for the gut and to protect effectively the gut from the adverse GI effects that's caused by oral iron. But it's also, as we found when we were developing the product, it's also better absorbed. It preserves iron in its absorbable 2+ or divalent form, to get technical about it, but it preserves iron in the form that's absorbable in the early part of the gut where iron is absorbed for longer. And so what we found, as well as being better tolerated, which was the original design of the product, it's also twice as bioavailable as ferrous sulfate, which is the golden standard.
Wow.
And so we prospectively treated these 59 women at 3 different doses. And what we found was that in this very difficult, perhaps, to treat patient cohort, they already have a vulnerability to adverse effects with oral iron. They're already deficient. The vast majority of them had to stop taking the prior oral iron product, over 80% of them. But it inverse. So 80% of these people were able to persist and do well on active iron over a 12-week period. Ferritin levels increased by almost 2-fold, 90% increase. Yeah, which is really useful. And what we found as well is that we looked at the quality of life of these women, and across SF36 health-related quality of life scores, pretty much all of the life scores or all of the various domains were normal, apart from the energy and fatigue score, which was well below 90%. In fact, it averaged around 60% for these women. So these women were really quite suffering, even with the low iron. Those scores improved, ferritin levels increased, and for the subset with iron deficiency anemia, we found that particularly the higher dose, 50 milligrams a day, normalized hemoglobin in the majority of patients, increased it by 1.35 grams per deciliter, which is, in that treatment period is a very substantial increase in this group of women who otherwise had given up on oral iron treatment. And as we know, certainly in this part of the world, if you've given up on oral iron treatment, you don't often get access to an iron infusion or to intravenous iron. So you're left to suffer.
As a GP as well, when you see patients in clinic, I mean, anecdotally, very few women actually have higher iron levels. And if they do, if I ask them, it's usually because they're taking iron supplementation already. And so actually, I would always encourage women to try and boost their levels to 80 to 100. But that's the thing, that's not necessarily a guideline. But what you've shown through the research is that actually it can be effective, and I think it's so exciting when there are pharmacological advances like this to actually allow that to be possible. Yes, we may recognise that there is an issue with heavier periods and iron loss, but if there isn't anything that's necessarily effective or kind to take, then we're still stuck in the same situation, unfortunately. So yeah, this is really, really exciting.
You'll both know well that for many years we were all taught not to treat, during the first trimester of pregnancy with oral iron products, even though it's the most obvious thing to do, because it was, it's an additional, they're a group, pregnant women are a group of people who need extra iron. But the reason that we were told not to take that preventative approach was, it turns out, purely because of side effects. And, now there's a lot more interest in trying to maybe address iron deficiency in pregnancy, but also, I think you mentioned earlier on, Marie, I mean, I think another area where there's a real lack of research is in that early postpartum phase. I mean, the precipitous drop in iron stores and in hemoglobin during childbirth is very rarely addressed. And it's sort of, sometimes gynecologists will put up their hands and say, well, look, we stop, our work stops when the baby is born. And then it's left to the GP to try and manage that. But often the patient is more focused on their child, the new baby, to really take proper care of herself. And she may need encouragement from pharmacists, from GPs, from midwives to really take those extra steps. But that's an area, I think, as well, that needs a lot more research and maybe more care and attention.
Yeah, absolutely, because it's only if a woman has a PPH that we will actually monitor her hemoglobin levels postnatally. And I think that is a conversation to be had, potentially around how we do address women that don't have a PPH but still have a very heavy blood loss postnatally and in the weeks following birth, because those are the ladies that can slip through the net, so to speak, and to become quite unwell without even realising that they've previously had a problem, because they've been told you've had a normal vaginal birth, everything is fine, everything is normal. 6 weeks down the line or 8 weeks down the line, they're left feeling absolutely battered and exhausted when they've been told, well, this is a normal part of childbirth, you've had a baby. When in fact, we need to be addressing that with the seriousness that it really deserves.
Yeah, and they present with a hemoglobin of 8 to the GP, and suddenly it's totally obvious that they need help, but they themselves have put the tiredness maybe of that anemia down to, well, I've been up all night with my child, or I'm feeding constantly, and I'm struggling to do all the things I need to do to mind my baby, and that's why I've been feeling awful, Yeah.
Exactly, and it may be something entirely simple that they just need an iron supplement to help them, and that will make them feel a hell of a lot better.
In the prospective study, we found that in these vulnerable patients with a history of intolerance to oral iron and iron deficiency, there was 5 times fewer adverse GI events experienced by patients and 4 times better compliance in comparison with the prior oral iron. And there were no differences between the 3 active iron dose groups, 14 milligrams, 25 milligrams, and 50 milligrams daily, in terms of compliance or tolerability, suggesting that higher active iron doses can be safely used, particularly in those with iron deficiency anemia. We also used the validated gastrointestinal symptom rating scale, which is a 15-question validated gut symptom score to systematically track adverse GI events. And this was used for the first time in an oral iron treatment study, and treatment with active iron resulted in, significantly better gut symptom score than the previous oral iron product. 85% of the patients improved their score, and there was no change in the gut symptom score over the 12-week treatment period, nor was there any difference between the active iron doses, which matches up with the compliance data or the adherence data. And finally, all of these patients had impaired ferritin, they'd impaired transferrin saturation at baseline, and half of them had anemia with hemoglobin levels below 12, and they all had reduced SF36 quality of life, energy and fatigue scores at baseline. And then over a 12-week period, there were overall improvements in the parameters observed, particularly in the 25 and the 50 milligram dose groups. There was over 90% increase in ferritin levels. There was a significant 20% increase in energy and fatigue scores. And in the women with iron deficiency anemia taking the 50 milligram dose, there was a 1.35 gram per deciliter increase in hemoglobin, meaning that most of these women had their hemoglobin normalized. So taking the screening and the treatment studies together, they show that really a self-report of oral iron intolerance in women with periods is a harbinger of adverse clinical status in the majority of patients related to low iron stores, and it's modifiable using active iron.
As a result of these findings from the clinical trial, I think it's really reassuring that healthcare professionals like ourselves can really confidently recommend iron supplements such as active iron for those that do need that supplementation, and in particular those women that have traditionally suffered from the GI effects of taking an iron supplement. Thanks ever so much for joining me, both Stephanie and Mark, to talk more about this really important topic in relation to women's health in general. So let's hope that this conversation continues.
Yeah, absolutely. Thank you.
Thank you.